thank you very much for the invitation to talk about a topic. And the only issue I have is that you want us to talk in 35 minutes about an issue in which I can talk all night. So if you have time, we'll continue after the session. This is my wife, Linda. So we are working together in a city called Hoofddorp, and which is translated as head village. And we consider it, of course, the most important city of the Netherlands. And you may have heard of one of our suburbs, which is called Amsterdam, but maybe you didn't. And the other point is we have an airport 5 kilometers from our office, so we have everything we want. We started with I started by incident, by accident getting involved in the ME/CFS in 2007 or so, and within a few weeks I saw more than 1,000 patients with ME/CFS symptomatology, and I thought, what the heck is this? So then, because there are vascular problems involved, we started with seeing ME/CFS patients, and at this moment 90.9% of our patients are patients with ME/CFS. So a lot of experience so far. So I'll talk about the orthostatic intolerance, not about the 2-day CPAT exercise stress test. We're talking about the orthostatic intolerance, which is quite a different ballgame. And just put it to the next slide. No disclosures, but I do want to stress that I want to discuss unapproved medical products in my presentation, which are not approved by official guidelines, but that's the way the situation is with ME/CFS. So I'm talking about the orthostatic intolerance, the symptomatology, how we can detect the orthostatic intolerance, and this is our main issue, the measurement of cerebral blood flow. And finally, I talk especially about from a patient perspective, the treatment of orthostatic intolerance. So this is the official definition. Orthostatic intolerance refers to a group of clinical conditions in which symptoms worsen with an upright posture, and many, but not all, are improved upon lying down. For example, fatigue and brain fog can persist long after assuming the recumbent posture. But if you go in specific detail of the symptoms, there are many symptoms of orthostatic intolerance. The most commonly known is the lightheadedness, of course, and syncope is, of course, an important one, but diminished concentration, headaches, vision problems, increase of fatigue, exercise intolerance, muscle weakness, pain, dyspnea, chest pain, palpitation, tremulousness, anxiety, sweating, nausea, hearing problem, blurred speech. They are very common problems and symptoms of the orthostatic intolerance. And in fact, I'm still amazed by the degree and very particular symptoms. And our opinion is that if some symptoms occur while sitting, standing, or walking, and disappear by lying down, it can be an orthostatic intolerance symptom until at least other symptoms other causes are excluded. For example, if you have a sprained ankle, then when you said going to stand on your ankle, then it of course causes pain. But that of course has nothing to do with the orthostatic intolerance, but more a local problem. But really, it's an amazing amount of various curious symptoms. So, for example, last week I had a patient who, while sitting up, she got around her nose a tingling feeling, only around her nose. And this one disappears when she was lying down. So In fact, if you consider your own symptoms and you think, is it something which is provoked by sitting up or walking or whatever, and disappears while lying down, then you should consider it as, although rare and bizarre, it's just an orthostatic intolerance symptom. And we specifically looked at the symptoms and the variety of symptoms during the tilt table test. If a patient is tilted, then we administer the questionnaire at minute 1 and after 10 minutes of standing. And here on the blue bars are the percentage of patients reporting symptoms. So more than 80% report dizziness, and increase in fatigue is on the second place. Muscle weakness, very frequent. Dyspnea, very frequent. And for me, it was a surprise that also visual and hearing problems are easily provoked by a tilt table test. So concentration, nausea, neck and shoulder pain, tingling of the hand, which is considered as an hyperventilation reaction, chest pain, low back pain. All these are prominent symptoms occurring during a tilt test. This is on the left side, and on the right side you see the same symptomatology in healthy controls. These are really boring people. They don't have any complaints at all. And in fact, that was really funny that if you explain to a healthy control that the symptoms, that they don't understand it. How can it be possible that they have this much of symptomatology while most of the patients have no complaints at all? Well, dizziness in the beginning that fades early away. So it's really it's a very, very prominent symptom in ME/CFS. The next one is that we always try to, because these are symptoms, we always try to get an objective assessment of the problems they mention during a tilt test. And one of the things you can easily just objectively demonstrate is the increase in pain. So usually pain is a sort of subjective feeling, but if you use a so-called algometer, that's a small device with a rubber tip at the end, and you put, as seen on the lower side figure, you put pressure with this rubber tip on the shoulder or the finger, whatever part of the body you want to move. You increase very gradually the pressure, and at some point, patients, but also healthy controls, will measure, will give that a start of pain. And this on the here on these two slides are the measurements of the finger and the shoulder of healthy volunteers. And so the shoulders are more sensitive than the fingers, but before on the left side and after there's no significant difference. So of course there is a pain experience if you increase the pressure, but it's not different from before and after the test. What I never showed, but what is the following problem, that healthy controls, the men can endure pain much more than women. Surprisingly, once I told it in the audience, I got almost rotten eggs to my head and tomatoes, because every woman thinks that men are pussy with regard to pain. But in fact, we have a very much higher pain threshold. So we should do the birth, etc. But okay, that's different in human life. But now on the next slide is the situation in patients. And the top slides are the patients without fibromyalgia or widespread pain syndrome, whatever name you have it for it. And on the lower side, you have the patients with fibromyalgia. And in the patient without fibromyalgia, the beginning, before the test, the pain threshold is the same. But after this, you see a significant decrease in the pain threshold. That means that if you have a less pressure, that they already start to experience pain. And that's the same in the finger here, before, after, and in the shoulder, before and after. This is highly significant. So in contrast to healthy controls, they have a reduction of the pain threshold, indicating that pain experience occurs earlier with a lower pressure of the algometer. And in the bottom side, you have the same situation in women these were all women with fibromyalgia. And of course, they have an increased pain perception. And if you press, so even milder in these patients, but there is again a difference before and after the test, you see that they experience pain at a much lower level. So this is just simple. You can really demonstrate that pain is a big issue, and that pain is also after a TIL test is already increasing. The next slide is the same. You have patients, almost all have problems with the memory and concentration. And you can also demonstrate that with the so-called NBEC test. And the NBEC test shows, in this case, characters or figures 1 second after another. And for example, if you have a one back test, you have to remember that your previous character was the same as the character as shown at that moment. So that's called the one back test. And if you see the same character, then you press a button and you get a correct or incorrect answer. In two back tests, the last and the same character in this kind of study was one in between, and the two back tests and three back tests there are two different characters between the right one at this moment and two earlier. We use the Cognitive for Fun website, and it's really amazing that some of the volunteers who are studying that, they could remember 9 figures back from the ones that show. 9 figures. I can't make it more than 3. Then I got easily mixed up. But I have an excuse. That's age. Then your working memory decreases. So if you are 25, you perform better, and if you are 75, then you should make a lot of mistakes. The next one is what we showed in these patients before and after the orthostatic stress or TIL pain test. Here on the left side, the upper side, on red are the correct answers and before the TIL test. And in blue ones are the correct numbers after the TIL test, 10 minutes after the TIL test. The 2-back test is easier to remember than the 3-back test. So you see that after the TIL test, both in the 2 and 3-back test, there is an increase in incorrect or decrease in incorrect answers. That's shown here. But also the time you need to make a decision, whether it's good or bad, increases after the TIL test, both for the 2 and 3-back test. So it's really, again, an objective measure of the memory and concentration problems that patients have. Yeah. That's another one, overlooked a lot of times. If you develop while sitting, standing, or blue feet, blue hands, etc., it's a sign of orthostatic intolerance. I don't know how many patients who are listening now do have the same problem, but I think so 1 in 10 of the patients do have this sort of feelings or visual appearances, mainly after, for example, taking a shower. So that's not to be taken lightly. It's a sign or symptom of the orthostatic intolerance. The next one, and this is an important one, that once you have an orthostatic stress, once you have and that we're coming back to later, you have a decrease in cerebral blood flow to your brain, then the orthostatic stress may result in a post-exertional malaise. And that's what we simply did in patients and in healthy controls, and we asked them to rate their pain and their fatigue and their concentration pre-pill test, post-pill test, but also 1, 2, and 7 days after the pill test. Again, in the bottom here are the blue lines, and these are the boring healthy controls, and there nothing changes after pre, post, 1 day, 2 days, and 7 days. But the thing is that in patients, and these were patients in red with fibromyalgia, they have an increase in pain after the pill test, and which lasts for 7 days. Much more pain than patients without fibromyalgia, here indicated in green. And you see also the increase in fatigue after the pill test, and which also may last for 7 days after a simple pill test. Again, also here in red, the fibromyalgia patient, but that's not significant from the patient without fibromyalgia. And also the problems in concentration increases after the pill test and may last for 7 days, or may last longer than 7 days. So the post-exertional malaise may be provoked by orthostatic stress, and it may last very long. Okay, so the summary is don't take the orthostatic intolerance symptoms too lightly. That's really a big issue, and if you're not aware of it, then you may overlook it, and you may perform PEM, etc., with a prolonged period of time. But the underlying point is, what is the cause of the orthostatic intolerance symptomatology? And there are 2 factors, and the most important one is shown here on the top. That's the reduction of cerebral blood flow. Blood flow goes to the head with the oxygen and with the nutrients, and the main nutrient is glucose. And if you have a reduction of blood flow to your head, then you get, of course, the dizziness and lightheadedness, and you get the headache, the vision problems, the muscle weakness, the impaired memory, concentration, the fatigue, the syncope, etc. But secondary to this reduction of flow to your brain is that the stress system gets activated, and you get palpitation, tremulousness, chest discomfort, chest pain, sweating, muscle tremors, etc. So these are the 2 main components. Yeah, if you have a particular symptom, for example, some patients get stomach problems, abdominal pain, then it's probably related not to the brain, but to the local organ that's underperfused. So, what is then the cause of the reduction in flow to the brain? There are 3 important ones, and the most important one is the gravity. The second one is the reduced blood volume. And in some patients, there are indications now that the ability to extract oxygen from the blood is decreased. To start here with the gravity, this is the circulation contains approximately 5 liters of blood, and which is of course circulated by the heart. And that still amazes me that when you stand up, and that also happens in healthy controls, then 700 ml to 1 liter disappears in the legs. So 1/5 of your circulation moves into your legs. And this is shown here, that here's the circulation while lying down. And almost, there's 1 liter, so that's 20% of the amount of blood goes to your legs. And in healthy controls, healthy people, this gravity effect is counterbalanced by constriction of arteries and veins of the legs, by returning the blood to the heart. And if it goes to the heart, then it of course goes to the brain. But in an ECFS, this counterbalancing effect is less effective than in healthy controls. So less blood returns to the heart, and thereby the heart only pumps out what gets in. Less blood is pumped out by the heart to the brain. So we can talk for hours about the exact mechanism, but this is the real problem about the gravity. We also demonstrated that by measuring cardiac output. This is a very complicated slide, but in the end, given here in red are the reductions in the amount of blood that the heart pumps out. In black are here the healthy controls. While standing, approximately 10% of the amount of blood that is pumped out by the heart is reduced while standing. But in patients, it's approximately 20 or more than 20%. So it doesn't get to the heart, and if it's not coming to the heart, then it's not pumped out to the brain. The second, and I still don't know if the importance of this one, it may contribute, but in ME/CFS patients versus healthy volunteers, there's a reduction in blood flow. That was brought to the attention by Sprint already in 1996, and in the early 2000s we were lucky to measure this blood volume. And here on the left you see and that's all measured while patients were lying down. The patients without orthostatic intolerance complaints in dark gray, and in patients with orthostatic intolerance complaints in light gray. And you see 100% is the normal value of the healthy controls. There's a slight reduction in patients without orthostatic intolerance complaints, but a 23% difference in total blood volume of patients who were having orthostatic intolerance. And blood is composed of two parts, the blood plasma here on the right, and the erythrocyte volume here in the middle, and exactly the same. There's no difference in this distribution. So if we could focus on the total blood volume, patients without orthostatic intolerance have almost near normal blood volume compared to healthy controls. But the ones who are really having orthostatic intolerance symptoms, there may be a reduction of 23 or more percent. I had one patient who had chronically a reduction of 1/3 of her blood volume without having any complaint. But that's major part. And here on this slide on the right side, it's an absolute quantification of blood volume in mLs per kilogram. But again, patients without in light gray with orthostatic intolerance symptoms have a larger, have a less blood volume, and compared to on the right side, compared to the healthy controls, we have a large reduction in patients without the orthostatic intolerance. So the third part of the reduction of the orthostatic intolerance are that in patients there are demonstrations that the amount of oxygen that is being extracted from the blood is less in patients. And this is a complicated slide here in orange. That's what we're talking about. That these are patients who need to deliver a large amount of blood to get the blood extracted. And this is during exercise. That's a different thing, but I presume that's also happening at rest. So much more blood is pumped to the organs, to the brain, well, to the legs, etc. Despite that, the oxygen consumption is much less than in purple here in the health controls. So they need a larger amount of blood to be pumped by the heart to get oxygen to the different organs. So gravity, blood volume, and a decreased extraction of blood by the organs, and that might be related to mitochondrial problems, but that's not quite sure at this moment. So how do we measure it, the orthostatic intolerance? Simply by inducing gravity effects. And there are three tests. The three most common are the tilt table test on top here, patients lying down, and patients positioned in the 70 degrees erect position. You have also a passive standing test, also very popular, in which patients lean against a wall for 10 minutes. And the so-called active standing test, then patients have to stand without support. That's the bravest test, because if you get a problem with your head and you're just standing on your own, you may collapse. But okay, I did that also, but there was one nurse standing beside me. If a patient did get problems, then she immediately pulled him and put him down, etc. Normally, the most usual measurement is the heart rate and the blood pressure, but you can add all kinds of fancy things like measuring the total amount of blood that the heart pumps out, an EEG of the brain. You can measure the flow to the brain, you can measure CO2, you get oxygen saturation, but these are mainly research questions. So, if you look and focus on the heart rate and blood pressure, you have in general 4 different responses. First, the POTS. Second, hypotension, that's the POTS is an increase in the heart rate. Orthostatic hypertension, decrease in blood pressure. Patients may faint, and finally we have a patient with a normal heart rate and normal blood pressure response. And this here on this slide is a beautiful image of a patient who is tilted, and you see an increase of the at the moment of tilt, a very rapid increase of the heart rate from approximately 110 to 190. Now that's abnormal. That's very abnormal. Usually in healthy volunteers, the heart rate goes up by 15 or 16 beats per minute. This is the orthostatic hypotension. Here is the tilt started, and gradually over time, the systolic blood pressure in red, the diastolic blood pressure in blue are decreasing. And you have well, that's a well-known, internationally accepted thing, is that the systolic blood pressure, if it drops more than 20, or the diastolic blood pressure drops more than 10, then you have an orthostatic delayed or immediate hypotension. Then the third one, of course, is a very obvious one. Here's a patient who started to tilt, and at this moment, before anything happened, she started to feel unwell. And suddenly, after 10-15 minutes, we got a very dramatic and very rapid decrease in the systolic in red and diastolic blood pressure. And you can imagine that these patients may faint if you don't tilt them back to the horizontal position. But the interesting part is that patients may also show a normal heart rate and blood pressure response, no POTS, no hypotension, and this is a typical example. There is a slight increase in the systolic blood pressure, slight increase in the diastolic blood pressure, and in essence, no change in the heart rate. And this sort of reaction is present in approximately 50% of patients. But one of the important things is that patients ask me a lot of time, I held a tilt test, nothing was shown, normal heart rate, normal blood pressure, but while I'm standing, I'm getting dizzy, nausea, etc. And if you look at the, if you carefully take the history, then we have found out that approximately 80% of patients do have orthostatic intolerance symptomatology. But if you do a tilt table test, then only 44% of the patients had hypotension, POTS, or near syncope. So there is a huge gap between the complaints of patients versus objective abnormalities. This is in line, this is a slide borrowed from Peter Rowe. From all the previous studies, approximately 42% of the patients had a orthostatic hypertension. POTS was not described, but that again is much lower than what we observed in patients. And so there are more orthostatic intolerance complaints than objective tilt table abnormalities. Sorry. And what it's all about is that the center of the problems is the reduction in cerebral blood flow. And by accident, luckily, I came upon a study of 1994 in which German authors measured blood flow in the vertebral and carotid arteries in healthy controls. And I thought, well, if Germans can do it, we can do it too. So we started to measure the cerebral blood flow in patients while lying down and during a tilt test. And you can easily access the flow to the brain. There are 4 arteries. Here in the front sides are the internal and external carotid arteries here. And it's all about internal carotid artery on both sides. And here, vaguely on you see small arteries going to the back of the brain. And you can measure blood flow, and you can while patients were supine and while patients are being tilted. It's not an easy technique, but it can be done. And this is an example of a patient who developed orthostatic intolerance problems. Here you measure the cerebral blood flow by combining the area of the vessel, which you can measure here at the top, with the blood flow velocity, which you can measure with the echo velocity devices, the Doppler. And you can see here, this was a patient being supine. In orange, in yellow is just the blood flow velocity. On the left, supine, and here on the right side, while being standing. And you don't have to be a rocket scientist to see that there's a huge difference in flow here, supine versus standing. So this is a nice demonstration that blood flow decreases while standing in these patients. And so we did a very large study in 400 plus patients, and we compared it in patients with healthy controls. In healthy controls, the reduction of blood flow while standing versus supine was 7%, so that's really nothing. And in all kind of patients, so including patients with a normal heart rate and blood pressure, patients with POTS, and patients with an orthostatic hypertension, sorry, the reduction in flow is around 26%, and that's a huge difference compared to the 7% reduction in the healthy controls. This is another one. I love these figures, so I'm gonna show a lot of figures to you here. We see the same. This is a patient with carotid artery, supine, and standing, and I repeated the test while patients had a compression stockings on. So there is reduction while standing, but while standing and patients do have a stocking on, then you see an almost normalization of the blood to the brain. And this is also interesting that here in these yellow things are the measurements of the amount of blood that's pumped out by the heart. You see here the baseline, a dramatic reduction in the amount of blood that the heart pumps out while standing, and a partial increase again in the cardiac output, so it's called, while patients have a stocking on. So this is a demonstration that stockings improve the circulation in these patients. And most importantly, and this is also a very important slide, that if you compare on the horizontal axis the reduction in cerebral blood flow versus the number of symptoms at the 10th minute of the tilt, using the same questionnaire, you see that the more severe the reduction in cerebral blood flow, the greater the number of complaints. But there is a huge variation, and that's really surprising. For example, this patient had almost no complaints, as he said, while his blood flow to the brain went 40% down. So you have to be aware of your symptomatology of the orthostatic intolerance to really appreciate what's going on in your brain. So 6% decrease in healthy controls. If you take a margin, and that's called 2 standard deviations for a lower limit of normal, so the maximum decrease in healthy controls is 14%. If you apply this 14%, then 90% patients have an abnormal cerebral blood flow decrease during the test. And also in 82% of patients who have a seemingly completely normal heart rate and blood pressure, but in 82% of these patients, blood to the brain goes down, etc. And now it's even getting more horrible that if you have a severe patient, then even a 20 instead of 70 and 20% tilt is really nothing. You see that in these patients, these severe patients, there's already a significant decrease in cerebral blood flow while undergoing a 20-degree tilt test. And similar, if a patient sits for a prolonged period of time, then in the patients without orthostatic intolerance, you see a large reduction in cerebral blood flow of 27%. And these were also the more severe patients. So even sitting, although you don't, it's not an acceptable thing, but even sitting can provoke the orthostatic intolerance. And finally, that's one of our recent findings, is that if you have a severe patient and you do the measurement during the tilt test and you lay the patients down and repeat the measurements, then in patients with mild disease, the blood to the brain immediately restores to pre-test values. In contrast, in patients with severe ME/CFS, the abnormality of the flow to the brain remains. So there are horizontal. Gravity is again normalized, but still they have a prolonged reduction of cerebral blood flow. And I think that may also contribute to the post-exertional malaise problems. So you have two things. How can we prevent the orthostatic intolerance by you, the patients? First of all, you have to recognize which orthostatic symptoms you have. One of the common things is to increase the water and salt intake at least 2.5 liters and 8 to 2 grams salt intake per day, or if that's difficult to measure, use the ORS for rehydration solution. Compression stockings, maybe combined with abdominal binders. Important one, showering. Warm, hot environment, a lot of orthostatic intolerance provocation. Do it less frequently, do it shorter, and use colder water if possible. Yeah, for me, that would be a bridge too far, but maybe it's in the time of high gas prices, colder water is the ideal solution. Cooking, do it seated. Toothbrushing, dressing, makeup, shaving, seated. Some patients really say that if they want to study something, they do it lying down. If it works for you, do it lying down. Avoid PEMS wherever possible, because orthostatic intolerance and post-exertional malaise go hand in hand. If you have by whatever reason you have a PEM, then the orthostatic intolerance symptomatology is increased. There's a big issue stated everywhere. You have to train your leg and abdominal muscles, and then everything will be cured, etc. That's a very overrated thing. Of course, train your muscles within your energy limits, but don't do it too much because you get a pain. You may use a heart rate watch with heart rate alerts. For example, if you're a patient with POTS and the heart rate goes above a certain limit, 30 or more above the baseline, then it's time to stop your activity, whatever you do. Standing still is getting the blood dropped to your legs, so don't stand still too long. Move one leg to the other because the muscle contractions improve the venous return. If you're somewhere in line in front of the cashier, just bend over your shopping cart. And if you're lying down on the couch, then elevate your legs again to increase the blood to your thorax and to your heart and to your brain. You may also try to use sitting on your legs. If you have a wheelchair, use it with a reclining seat. And when you have orthostatic intolerance and you are in the supermarket, don't be shy, just lay down and tell them that you are shocked and almost syncope complaints because of the high prices, but it's a different matter. So just lay down whenever possible. And then finally, there's a lot of medical treatment which can be prescribed by physicians. Propranolol, ivabradine, which reduces the heart rate, improves filling time of the heart. Mestinon, it improves the return of blood to the heart, it lowers the heart rate. Fluorocortisone and desmopressin may fill up your circulation by retention of water and salt. In case of orthostatic hypertension, midodrine, because it improves blood pressure. And funny enough, mast cell abnormalities, they also help for the orthostatic intolerance. The mechanism is completely unclear at this moment, but it may help. Clonidine may reduce the nervous system activity, stress nervous system. Sometimes the physiological salines in a limited number of patients will improve the circulation. It may help. It's a complicated thing. There's a lot of complications. And one important or two important things I want to mention is that many patients experience side effects using medication. Why they have more side effects than other patients who use medication, I don't know. But I always say jokingly, if a patient has no side effects, then I really start to worry. And secondly, the other thing is that, and that's also surprising, whatever drug you use, it is effective in maximally 50 to 65% of patients. Why? I don't know. If you should give Mestinon, why doesn't all patients improve? But that's not the real world situation. For example, if you treat patients with Mestinon, then in red are the patients who improve, in blue no effect, and there are a lot of patients with side effects. So if you have a positive side effect and you compare it to patients who have no effect or with side effects, then 50% of the patients do respond to the Mestinon treatment, and it's similar to other drugs. And if you compare only the patients who tolerate it, no side effects, then it's effective in 63%. So it does. If it doesn't work, it doesn't mean it's your problem. No, it's a problem of the drugs. So conclusion. Orthostatic intolerance complaints and objective signs of POTS and orthostatic hypertension are very prevalent in CFS patients. The symptomatology is highly diverse and bizarre even, and I'm still getting sometimes, even now after 15 years, how the hell is it happening and what's happening. But these complaints, how bizarre, they are real, and a majority of the patients can be objectified. The core problem is the decrease in cerebral blood flow while sitting, standing, and walking in CFS patients, in contrast to healthy controls. But even if there are no blood pressure or heart rate abnormalities, an abnormal cerebral blood flow is present in patients with a normal heart rate and blood pressure response. And the more cerebral blood flow abnormalities you have, the more orthostatic intolerance complaints you have. So that's the end of my presentation.
You have to choose between your stomach and your brain. In my opinion, that's not a difficult one, but probably for this person it is. When you're going up from lying down to 20% or more upright, you're getting your brain into trouble, increasing your PEM and increasing your orthostatic intolerance. Any other symptomatology like gastrointestinal problems maybe should be fixed otherwise in a different manner, being able to calm down your CFS by lying down and not increasing it by comforting your gastrointestinal problem. Irrespective of how much and how long you're lying down, because indeed it takes too much effort to take them off every time you're lying down. But if you have them on during the day, when you go out maybe for the toilet more often than you do in the night, then you may benefit a little bit from the compression, having them on at that time. It doesn't hurt you when you're lying down, having them on. You should not have them on for 24 hours a day, obviously, but maybe have a help with that by a nurse or somebody, or a healthcare, or your friend or whatever living with you.
Very healthy. There are some handy devices to help you with putting on the stocking.
Yeah.
And putting off.
Some of the stockings companies will have aids putting them off. Putting on stockings yourself with your hands is more difficult. We do obviously cerebral blood flow measurements, and next to the devices with heart rate and blood pressure on the finger, plethysmography, which kind of extrapolate also cardiac index, we use cardiac Doppler, determining cardiac index, which is more of the gold standard. And when you're talking about what this person is calling hyperpods, you see no change in cardiac index, which means that the adrenergic state of this person is that high that it's a decrease in stroke volume is compensated by heart rate increase, which is usually when the heart rate goes up more than 40. If the blood pressure stays the same, obviously, because if your blood pressure goes down, an increase in heart rate is compensatory, and it's not called POTS.
So, to be practical, if you have a heart rate increase between 30 and 40, it's the venous cooling POTS, and above 40, we call it the
hyperadrenergic POTS. Yeah.
We try to measure the adrenaline and noradrenaline, and it was so hard because you have to get it immediately to a laboratory. And in fact, in all patients it was normal. So, but that may be a difficulty of the laboratory assessment.
Yeah. Post-exertional malaise, obviously. And the question is the high heart rate while standing up showing a decrease in blood pressure, then it's obviously no POTS. Then you can get orthostatic intolerance symptoms by that. And like when you are in a worse situation, lying down again, your cerebral blood flow will not be normal right away, and you will have the same symptomatology for maybe even up to 10, 15, 20, 30 minutes lying down because the situation is not returned to normal yet. You can have, because of the decreased blood volume, when you are upright, you can have kind of a squeezing hypertension, which is not a real hypertension. So for ME/CFS patients, we recommend only to use supine blood pressure measurements just after, not directly after waking up, because waking up is a stressful thing. Have a supine period of at least 30 minutes, measure blood pressure at least 3 times in a row, and note down the second and the third measurement. If lying down measurements are normal, you don't have a hypertension. If lying down blood pressure is normal, going up, standing or sitting, you get hypertensive, it's not hypertension to be treated.
So in conclusion, get off the Coversil.
Probably, yeah. Probably fibromyalgia. And what you see, what Professor Visser has shown is that when you have orthostatic stress, and also that happens after exercise, normally pain thresholds go up after exercise. In ME/CFS patients, pain thresholds go down, not only after exercise, but also after orthostatic stress. So any sign you have from the brain, from the pain center, that will trigger pain, you will feel more because your pain threshold is lower. Blunt first response is no.
Okay.
Leg exercise obviously can train your muscles a little bit, but it will not improve your cerebral blood flow. Yoga, no, probably not.
We're getting in muddy waters. I don't know. There's some patients who do really respond well on yoga, etc. And then we have this.
But we have not proven that it will
No,
increase cerebral blood flow.
No, that's right. But yeah, it may be. I'm less sure than you are.
I'm pretty blunt all the time. I was telling, if you please lie down and use that as the normal blood pressure. Seated or standing in ME/CFS can be abnormal, but is not usually, if the lying down version of blood pressure is normal, is not a sign of hypertension.
In quite a few patients, and in these patients, there are no signs of
left ventricular
hypertrophy of the heart or inflow problems of the heart. The EKG is normal in these patients. So if you don't have any sign of any organ abnormality in this sort of seated or standing hypertension, nothing is wrong.
Can be. You can be out of balance also due to a cerebral blood flow decline. Some people describe the symptom of dizziness not as good as other people do. So it can be. HPV vaccine can be a trigger for ME/CFS. And if you have ME/CFS, you will have orthostatic intolerance in 90% of patients. So yes. I'm probably one of the cardiologists having a metabolic signature, having a diabetes training. If I'm reading stroke, I'm thinking with numbness, is it neuropathia from diabetes maybe? I'm thinking more into that direction other than blaming it on any CFS directly. If you get a decline in blood pressure and get a reaction in heart rate for 30 beats per minute or more, then it's not POTS. You can have a reaction of POTS where your blood pressure stays normal or even gets higher, and after that get a delayed orthostatic hypertension. That's possible. But having a lower blood pressure and an increasing heart rate, that's not POTS.
Okay. So the POTS can be followed by an orthostatic hypertension, or can be followed even by syncope.
It can be because they probably during the day when they are awake they have to pee or go to the toilet at one point or another, and then compression to the legs can be helpful, but you have to take into account how much effort does it take to put them on. And maybe in when they're severe, maybe abdominal binders, maybe less taking less energy putting them on.
Yeah, but if you take on abdominal binders without compression stockings, then you may block the re-entry from the legs to the abdomen.
That's also true.
I always say with everything, try it and see if you improve. And that's the same with medication or supplements or what intervention you do, try it for a period of time, 1 month, 2 months. If it doesn't work, stop it. Don't do it anymore.
Well, in my blunt opinion, if you have a higher heart rate than what you expect to be normal, then that's a sign of being in a severe condition of ME/CFS, and you're getting over your boundaries way too much. So lying down more, longer, flatter, for a prolonged period of time, because when you stay within boundaries, you will only save 1 minute per week. So it will take an incredible amount of effort saving up energy to improve your heart rate. The other thing is vasospasm angina.
That's not part of
it's not part of the ME/CFS.
No, definitely not. But you may have chest pain.
Of course, but that's because of you get hypocapnic because of an abnormal response of the respiratory center in your brain, because it gets less blood during the standing up. So we see a lot of patients, and some researchers have called that orthostatic hyperventilation. We used to call it hypocapnia, just describing that you're getting rid of the CO2, which gives you a lot of complaints. Obviously, it's not normal when you're ill.
Yeah.
Post-viral fatigue is ME/CFS, period. POTS is orthostatic intolerance as part of the symptomatology, and with cerebral blood flow decline as part of the orthostatic intolerance problems, hypoperfusion of the cerebral regions can happen, and depending on which region will get you hyperperfused, that decides which symptoms you will get from that. So this is possible. It's quite a long time. So when it's such a long time, the amount of stress put on the system was quite extensive.
You may consider that also while having decollapse, is that a concussion occurred of the brain,
that's
and
also
then
possible.
you're way a month out of business.
Yeah, that's also possible. Depends on how you measure the pulse, because sometimes Fitbits or smartwatches or whatever don't take up every beat your heart does when there's some extras, some extra systole or something like that.
Yeah, but if you have a low blood pressure and a low heart rate, that's part of the game.
Yeah.
And so it can be just part of the whole symptomatology, orthostatic symptomatology. So yeah, it happens. And if you have a low heart rate and a low blood pressure, that makes treatment more difficult.
No, it's not the same. There's a lady in US which stole this pulse pressure idea from Professor Rowe. It's kind of a consequence of what happens. It's not a sign that you can make your decisions on. It's not like my pulse pressure has come down like this and this and this. What medication will I take? No, that's not how it works.
No, but on the other hand, you see also on one of my examples that the pulse pressure, which is the difference between systolic and diastolic pressure, decreases during stress. Okay, you can't use it as a test,
no,
but it's a very common finding. No, but I tried it sometimes in the patients, and it's very disappointing. But some do improve.
Yeah,
that's a big minority.
It almost sounds like this is a hypermobile person. And in hypermobile person, dysautonomia, which orthostatic intolerance and POTS is obviously a part of, can also extend to gastroparesis and bowel motility issues and even bladder issues. So it can be, well, you have to go to a what's an NDL doctor? Gastroenterologist. But a lot of gastroenterologists in Netherlands don't have a clue about bowel motility disturbances. So I'm not sure how it's in Ireland on that topic.
Gastric motility study or colonic motility study, that should be possible also in Ireland, because it's, for example, with the stomach, you can eat a small radioactive pancake and see how fast it goes out of your stomach. So there are easy ways to get it done.
This is wrong breathing due to cerebral blood flow decline by being upright, and the only way to handle that at first is lying down and make sure your cerebral blood flow improves, stay within your boundaries, and then when you're doing that, having enough fluids, having enough salt. One of the medications that were on one of the last slides of Professor Visser might help, but if you're not staying within boundaries, any drug will have not a very good chance of helping you out.
Now, but the point is, once you have not only the chest pain, but also the dizziness, also the nausea, once it happens during, well, an orthostatic problem, then it may in some patients stay there for days, weeks, years. And in this case, the simple ibuprofen or paracetamol or etoricoxib may help to relieve the pain. It has nothing to do with your heart, nothing to do with the lungs, nothing to with the lung blades, etc.
No,
so it's
cerebral.
It's an innocent thing, but a very potentially worrying thing. So don't worry. Take any pain medication, and yeah, take a rest and see what happens. But it may be present for a long time in patients.
Mm-hmm. You have a lot of things in this topic. Long haul COVID is ME/CFS, we think. COVID also is a very potent trigger. So ME/CFS patients getting that will have a bigger and longer period of crash/PEM than after a regular flu or cold. They will get to their pre-COVID position, but it will take time, maybe even up to a year sometimes. And because the PEM reaction to COVID is that prolonged, we advise actually to have patients taking their vaccines for that.
At this moment, there are more and more evidence that the mast cells will be involved. So at this moment, if patients take a booster, which we are very well, we promoted to do it, then taken in this period before, for example, a week before to 2 weeks after, an antihistamine, and it may reduce the the side effects of the booster. It's not at this moment crystallized, no randomized trials, but I think it's fair to do because they're innocent drugs.
It's an ME/CFS response. Your blood is less, your blood volume is less. Of that, the normal compared to healthy controls amount of blood will go down to your legs due to standing. So there's less left in your arms. So the arteries in your arms will feel a little bit lonely with a little bit of blood in that, and they will kind of contract, and contract artery in arm will show a higher blood pressure. So it's just a squeezing blood pressure. It's not a real hypertension. Orthostatic hypotension. We hope so, but it depends on where the money goes to. If the money goes to really basal things like microbiomics or genes or whatever, it will take a long way to find answers for the clinical practice. But we hope getting more money into long haul COVID, hoping to get more understanding also for ME/CFS, obviously.